Medical malpractice claims may be asserted against any healthcare practitioner, including nurses. This case study involves a registered nurse responsible for the post-operative care of a patient where the RN was also supervising and providing direction to an LPN. In reviewing this case, it is important to understand the difference in practice authority between an RN and an LPN or LVN. In general, an LPN or LVN performs fundamental care responsibilities under the supervision of RNs and physicians, while an RN performs more complex tasks such as administering medications and creating and coordinating care plans. For further clarification, it is recommended you review the Nurse Practice Act in the state or states where you are licensed to practice. The decedent or plaintiff was a 67-year-old male who underwent a right total knee replacement. Following one episode of hypotension, which was treated successfully with ephedrine, the plaintiff was transferred to the post-acute critical care unit with the epidural in place. Although the defendant nurse customarily worked as a charge nurse on the medical surgical nursing care unit, she had been reassigned to the post-acute critical care unit. The defendant, a registered nurse, stated that she understood her assignment at the time of the plaintiff's admission to this unit and was to provide oversight of the patient care to the entire floor for that shift. In addition to her duties as the charge nurse for the unit, the defendant nurse was assigned to assess the plaintiff and oversee his care. The defendant nurse assessed the plaintiff upon his admission to the unit and found him to be stable. The defendant nurse understood that the direct care of the plaintiff was assigned to a co-defendant licensed practical nurse, or LPN. However, the nurse failed to document a plan of care that included care of the epidural catheter and additional monitoring of vital signs for hypotension. What would be the appropriate actions for the nurse working with an LPN for this admission? Think about what would be the appropriate delegation of work and method of delegation from a nurse to an LPN. Additionally, given the patient had an epidural catheter, what side effects should the nurse have been watching for? The nurse should be familiar with the patient's recovery status, know what medication is running in the epidural, and know what signs and symptoms, adverse reactions, and complications to watch for. Does your hospital have a policy and procedure or a protocol for caring for an epidural? Each staff member is responsible to ensure clarity regarding their direct care patient assignments, as well as any supervisory or monitoring duties that are assigned. Clearly document assignments at the start of the shift and include and communicate any modifications to the assignment during the shift. This is even more critical when staff typically assigned to other areas is floated to the unit. Be clear on what signs and symptoms you want reported immediately. Fully assess patients upon admission to a unit and notify a practitioner if any patient is deemed unstable or if care and monitoring is required beyond that which is provided on the nursing unit. Provide the practitioner with the patient's specific clinical signs and symptoms. Approximately 3 hours after arriving on the unit, the plaintiff was unable to tolerate ordered respiratory therapy due to nausea and vomiting. According to the insured registered nurse, approximately 10 minutes after an episode of vomiting, the LPN found the plaintiff cyanotic and unresponsive and immediately called a code. The RN should be familiar with the patient's recovery status, know what medication is running in the epidural, and know what signs and symptoms, adverse reactions, and complications to watch for. If the RN had never cared for a patient recovering from a knee replacement, it would be appropriate for her to look up the care and clarify the orders with the practitioner. A patient with an epidural catheter is at risk for hypotension and respiratory depression. An increase in vital signs and O2 saturation monitoring should be implemented for a post-operative patient with an epidural catheter, especially one who has already experienced hypotension. Clear documentation of vital sign data is a standard of care. A newly post-op patient with an epidural should have frequent vital signs. An example would be every 30 minutes times 2, every hour times 4, every 2 hours times 4, then every 4 if stable. Vital signs and pulse oximeter data should be documented in real time and changes communicated to the practitioner. Ongoing assessment of a newly post-op patient is the responsibility of the RN. The defendant registered nurse responded, as did the code team, and the plaintiff was intubated and transferred to ICU. This account of events was disputed by the LPN and 2 other staff on the unit who understood that the defendant registered nurse was responsible for the direct care of the plaintiff. The LPN stated that it was the defendant nurse who found the plaintiff to be unresponsive at some point after the last episode of vomiting and called the code herself. The elapsed time between the episode of vomiting and the code is also disputed. The eventual diagnosis was anoxic encephalopathy due to the time that elapsed before CPR was initiated. The prognosis was poor and life support was withdrawn. The plaintiff breathed independently and was transferred to hospice care, where he subsequently expired. A review of the case study reveals the following. There is some question whether the patient was, in fact, stable when admitted to the post-acute critical care unit. There may have been miscommunication among the nursing staff, as the defendant nurse did not usually work on the unit where this event occurred. In addition, the defendant nurse seemingly misunderstood both her assignment as well as the assignment of the LPN. Ordered vital signs and respiratory assessment were not documented. The fact that the plaintiff had experienced hypotension in the recovery room should have warranted even closer observation. The episode of nausea and vomiting should have resulted in additional observation and notice to the physician. Failure to understand and differentiate the role of the LPN and clearly provide direction, plan of care, and oversight played a large role in this case. Each staff member is responsible to ensure clarity regarding their direct care patient assignments and monitoring duties. Clearly document assignments. Failure to differentiate roles also led to a failure to follow the MD post-operative orders and failure to notify the MD of the change in patient's condition. Finally, a failure to initiate CPR upon finding the plaintiff unresponsive also played a role in this case, leading to allegations of failure to rescue. A lawsuit was filed on behalf of the deceased plaintiff alleging malpractice against multiple providers, including the insured nurse and LPN. Given that the timeline and events in this case are disputed by the team, it would lead the plaintiff's attorneys to believe that communication and teamwork for this patient was absent. Experts determined that the defendant nurse had breached the standard of care in the following areas, including failure to formally clarify her work assignment, failure to properly assess the plaintiff, failure to properly supervise the LPN, failure to follow physician post-operative care orders, failure to notify the physician of changes in the plaintiff's condition, and failure to initiate CPR immediately upon finding the plaintiff to be unresponsive. Would clear communication between the nurse and physician and between the nurse and LPN have changed the outcome of this case? What if the nurse asked herself, "What am I concerned about with this patient?" The fact that the plaintiff had experienced hypotension in the recovery room should have warranted close observation. The episode of nausea and vomiting should have resulted in additional observation and notice to the physician, and ordered vital signs and checks were not documented. Given the departures from the standard of care and the conflicting pejorative testimony of other staff members regarding the defendant nurse's care, the decision was made to settle the case on behalf of the defendant nurse. The total cost to defend and resolve the claim was greater than $260,000. A review of the case study reveals the following. If the RN was responsible for oversight of the entire unit, it would be reasonable to think that the RN also made out the patient assignment. Since this RN had charge experience, was it appropriate to assign this fresh post-op patient to an LPN? In the state that this case occurred, what does the RN and LPN Practice Act say about scope of practice and accountability? What could the RN have done to better clarify and communicate the assignment? In summary, remember that each staff member is responsible to ensure clarity regarding their direct care patient assignments, as well as any supervisory or monitoring duties that are assigned. This is even more critical when staff typically assigned to other areas is floated to the unit. Patients should be fully assessed upon admission to a unit. Notify a practitioner if any patient is deemed unstable or if care and monitoring is required beyond that which is provided on the nursing unit. This completes our nursing malpractice case study on failure to assess and monitor. Access a full range of helpful information that you can use every day in your nursing practice by visiting NSO.com.